We're here to talk about really cancer and sexuality, and I got a call just this last week asking if I was really going to talk about just female issues or talking about male issues also. I think you'll find that a lot of this applies to male sexuality also, but my specialty is female sexual medicine. So I work for Urology San Antonio, which is the largest urology group practice in South Texas. People ask me all the time, how did I get into urology? How did I get into sexual medicine? Kind of found me. So let's get started. Disclosures, and when we do talks, we always have disclosures. Nobody's paying me to speak today. I'm not endorsing anything in particular. So there they are. Objectives, we always like to have objectives. You can read that. We're going to talk about various aspects of sexuality and specifically female sexual medicine. One of my favorite slides, this is the female woman's remote. If you'll look right here, my favorite part is down here at the bottom. Make me a bath, make me a drink, make me a queen. Start complimenting, stop complaining, pause to apologize. Here's the woman's remote. Now this is an interactive thing, so when I put something up that I think is funny and you don't laugh, you make me really uncomfortable. So that was supposed to be funny. Terminology. One of my favorite authors when we talk about sexuality is Ann Katz, and I have a couple of her books up here. These are my books, so you're welcome to look at them, but please leave them back with me because they're my friends. I think that Ann Katz, and you'll see I refer to her on a regular basis, really has a good grasp of sexuality. And she talks about sexuality being how we experience and express ourselves as sexual beings. But our functioning is what we're able to do as sexual beings. And sexual activity, there's a lot of definitions of sexual activity. She says, today most women who receive a cancer diagnosis will go on to survive, and in time the memory of cancer and its treatments will fade. Sexuality is a part of life, and women deserve to continue to express themselves as sexual beings in loving relationships. And I would venture to say that comes from her Women, Cancer, Sex book. And I think that you can insert men also deserve to be sexual beings in loving relationships. But I like how she says that. There's a lot of issues related to not just cancer and sexuality, but really any chronic disease and sexuality. When we deal with altered body images, when we deal with the consequences of physical changes that happen with treatments and with chronic illness, a lot of psychological and psychosocial consequences. The relationship dynamics changes, quality of life changes. You go through different stages of illness, and really, bottom line, facing your mortality. You know, some people have not faced their mortality until they get a chronic illness or they get cancer. This slide I put up to show you that I truly believe that one of the most beneficial things that any woman can do, and not just women who have cancer issues or a chronic health issue, is to know your body. Know what your body looks like, feels like, smells like. I think it's really important. I see patients on a regular basis who really have never inspected their own bodies. And what I say about sexuality is, how can you expect him to turn you on if you don't even know where your switch is? So I do believe that we need to know our own bodies. You know, how does it function? How does it work? What does it feel like? What feels good? What feels bad? There are a lot of wonderful resources out there to help you understand your own body. And men, I would say there's some out there for you also. I just don't have them in my office. ACOG is the American College of Obstetrics and Gynecology. This just happens to be one of their brochures that deals with sexuality and sexual problems. There's a lot out there, and don't be afraid to Google some of these issues. It doesn't always take you to those sex websites, so you don't have to worry about that. But I think it's really important. I found this in a publication by Child Trends, that when you leave untreated and internalize your problems such as depression, anxiety, negative self-perceptions, emotional distress, you can undermine your ability to succeed in school, to live a healthy lifestyle, to form and maintain close relationships with others, and in general to accomplish your goals. So I think it's really important that you address the things that you're feeling. And sexuality is just a part of who you are as a healthy person. I'm going to do a brief discussion of female hormones because I think to understand what happens to a body when it's forced into menopause, you need a better understanding of how the body works originally before you had to deal with either a chronic illness or cancer. The three estrogens are estradiol, estriol, and estrone. Estradiol is the estrogen that is what we consider the weakest estrogen. It was at its highest level in pregnancy, so most women will tell you when they were pregnant they felt really well. It's because they had a higher level of estriol, but it's a weak estrogen. Estradiol, particularly 17-beta estradiol, is the hormone, the estrogen hormone, that when we're giving replacement therapy back, we pretty much use a lot of estradiol. We also call that E2. Estrone is the hormone, the estrogen hormone, that is, it's as high its peak in menopause, but it's not as accessible. It's not an estrogen that goes to work quite as well. It's converted to estriol and estradiol in the body. Then you have progestins or progesterone and testosterone. So a simple way to understand this is in a body, in a woman's body that is through puberty and is functioning what we call fairly normally in a regular cycle, periods every month, your estrogen level is this line here. This is a month. From here to here is a month. So your estrogen level goes up. This is about mid-cycle. This is where women tend to feel the best, where they tend to have a egg white type discharge preparing for the possibility of pregnancy. Then it dips down like this. Progesterone is the hormone that we call, I call it the housekeeper. Progesterone comes along and peaks mid-cycle. This is PMS right here. If you want to see it in graph form, it's right here. When the progesterone peaks, when it's high level, that's when women have the worst issues with PMS. But the progesterone is really important to offset what the estrogen's doing to the lining of the uterus. So if you think about estrogen building up the lining of the uterus, then progesterone comes along, and when they both drop right here, that's when, if there's not been implantation for a pregnancy, that's when the bleeding occurs. So that's a regular ovulation cycle. Sexual desire, when you correlate it with that, if you can put one on top of the other, this is also the peak when your estrogen level was up. All of this to say that when you hit menopause, actually a lot of women, before they hit menopause, when they're in perimenopause, I think that's the most obnoxious stage of our life, perimenopause. And I think probably because those were my most difficult patients when I worked in gynecology, and because I had trouble getting through it myself. There's so many variables. You know, when you're going through perimenopause, are you going to have more frequent periods or less frequent periods? Are you going to bleed heavier or lighter? Are you going to have better PMS or not have PMS? So a lot of variables there. But in essence, when your estrogen level is at a pretty significant place, then sexually you have more desire. This is also, if you think about how nature works, when your estrogen level is high and you are producing that viscous discharge, that makes the best kind of discharge for the swimmers to get where they need for fertilization of an egg. Now, when you look at the changes that your body goes through in terms of aging, so down here is late reproductive years, and then this is no more periods, and this is after. So estradiol, right before everything crashes, it seems to peak. And then look what it does, bottoms out. On the same token, FSH is follicle stimulating hormone. Hormone produced by the pituitary when it's trying to get the ovaries to wake up and function. So when you do blood testing to see if a woman's menopausal, a lot of times all you're looking at is what is her follicle stimulating hormone level, because if it's really elevated, then she's likely to be in menopause. So your follicle stimulating hormone skyrockets and your estrogen level plummets. And most women will say, I don't feel very good. Testosterone pretty much does the same thing. We certainly have a little bit of testosterone, but it drops as we age. All this to lead us into menopausal terminology. So there certainly is the very simple top three. When you start your period as menarche, perimenopause is when you're slowing down and kind of headed into menopause. That's the one that I said I think is the most obnoxious stage of a woman's life. If we just sent a bunch of perimenopausal and menopausal women overseas with guns, we could fix that whole ISIS problem. You just leave a sign on them. Have you seen that T-shirt that says "I'm menopausal and I have a gun"? So, and I'm out of hormones, I think, is the third thing. Yeah. Postmenopause. Some resources don't even use the terminology postmenopause. Menopause is defined as no periods for a year. So once that year is over, are you called menopausal or postmenopausal? I don't think it really makes a difference. But the three that you want to look at when it comes to a cancer diagnosis, even a chronic illness that involves a lot of pretty high dose and heavy duty medications, are early or premature menopause. That means that something has shut the ovaries down early, and a lot of times chemo will do that. Induced menopause, if they have determined that circulating hormones are actually feeding the cancer, they may give you a medication to slow down the production of hormones to slow down the production of the cancer. And then surgical menopause is obviously, I hope, a hysterectomy where you take out the uterus and the ovaries and it's, cold turkey. So those are the three stages of menopause. Now, I didn't say this ahead of time, but anytime you have a question, you don't have to wait till the end. Just wave your hand and holler at me. World Health Organization, and I think this is another really important quote that I like to use, is that sexual health is a state of physical, mental, and social well-being in relation to sexuality. It requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences, free of coercion, discrimination, or violence. So again, I go back to, how did I get into sexual medicine? In fact, my ex-husband said, I hope they don't consider you an expert in sex because we never had enough sex for you to be considered an expert. So I don't really consider myself an expert in sex, but I'm willing to talk about it. And I think sexuality is one of those things that for a lot of people is very uncomfortable to talk about. When I see patients, when I talk about sexual medicine, I say, there's three reasons that we got into sexual medicine in the urology office. The first reason is because we're already doing male sexual medicine, so it made sense to do female sexual medicine also because we're experts in the pelvis. Another reason is that in the continence center, and continence means dry, so that's where you come when you're leaking urine and I help you get dry. We do a treatment called pelvic floor therapy where we work with that hammock of muscles called the pelvic floor. That's where the urethra and the rectum pass through, and in women, the vagina. So when we were doing those treatments, women were saying, hey, by the way, my sex life's better. But the third reason is because nobody else has done it. So, I really thought that in the OB-GYN world, they'd pick up the ball and run with it, and they have not. So I think what you're going to find is you just have to look for somebody that is comfortable enough in their own skin and comfortable enough discussing it. Well, I had 2 boys, so you can't really shock me with anything. I've heard it all. So I don't have any problem talking about sexuality. I don't have any problem with talking about your body. So I think that's why patients come to me for sexual medicine issues. But I think it's very important that you think of it as sexual health. So when we look at the response cycle, Masters and Johnson were the first to kind of identify the cycle, and they just said there's a desire phase, an excitement phase, then you orgasm, and you either resolve or you plateau. Well, if you think about that, that's really pretty a linear description of sex, of intercourse. And for most men, that description fits very well. For a lot of women, it doesn't. So Rosemary Bassan came up with this model. Oh, this is another cartoon. They're in with the marriage counselor, and she says, "He ceases to amaze me." I thought that was funny. Thank you, thank you. Rosemary Bassan came up with this model that actually put it kind of in a cycle, because what she said, and I think she's absolutely spot on, is that this spontaneous sexual drive sometimes enters in different spots. Sometimes for women, we just need to get started. So men don't understand that. You guys are wired differently. Women, for a lot of times, we need something to get the ball rolling. So one of the metaphors that I use is men are microwaves and women are crock pots. And as we age, as we deal with life stressors, as we deal with things like cancer and chronic illnesses, that crock pot is harder to turn on, much less get it hot enough to do anything. Now, I also feel like you can either sit back and cry about that, or you can sit back and laugh about it and figure out, okay, how do we get this crock pot hot? You know, what do we need to do to kind of warm things up? Because things are different. Things are different. We don't work the same. You guys, you microwaves, you pretty much work the same all the time. Women, things are different. Childbirth changes things down there. Losing the estrogen down there in particular makes the tissue thin, pale, and dry. When you've had either a surgical menopause, induced menopause, whatever causes changes down there affects your crock pot. So just think about it in those terms. What can you do to make your crock pot warm up? One of my other favorite books is by Harriet Lerner, Marriage Rules, a manual for the married and couple up. And she says sex is a lot like pizza. No matter how bad it is, it still can be pretty good. But a poor sexual relationship can throw a wrench in your relationship. Yes, ma'am?
Are these slides going to be available, or are they printouts, or
They can be. They can be, yeah. You can use my business card. Actually, they have them. They have them. I sent them to them.
like email?
Yeah.
Video.
Yeah.
Oh, video. Oh, thank you.
So you're welcome to do that. So that comes from Harriet Lerner. I think she's an awesome author, and I like some of her perspective when it comes to not only sexual issues, but relationship issues. So the terms FSH, FSM, and FSD. The most common term is female sexual medicine. But the nurse in me says, why are we calling it medicine? You know, I'm a nurse. Why are we calling it medicine? So I prefer to think of it as female sexual health. But FSH stands for follicle stimulating hormone, and that acronym was already taken. But I usually call it in my notes female sexual health. Female sexual dysfunction is literally defined as sexuality that's causing the patient distress. So hear me out here. I see plenty of patients for sexual issues, but it doesn't bother them a bit. If it doesn't bother them a bit, it's not a dysfunction. So I'm really careful when I use the word dysfunction. I don't like the word dysfunction. I wish we had a different term for erectile dysfunction, but we don't. So in female sexual, FSD, female sexual dysfunction, it's only dysfunction if it causes the patient distress. So I've seen plenty of patients that either partner can't function anymore, and they still have a very close, very active sexual relationship, but their sexual activity is different than your generic penis and vagina intercourse. They can't do that anymore, but they have a very active sex life. Neither one of them has, I wouldn't use dysfunction. because they're perfectly happy. So I don't think you have to have penis and vagina sex if you as a couple have decided you don't need to do that anymore, or you can't do that anymore, and you're perfectly happy. The 4 types of dysfunction refer to desire, arousal, orgasm, and pain. The one that's the most prominent is desire. I just don't feel like doing it. And the most common cause of that in females is our very busy lifestyle. One of the metaphors I like to use is that for men, I think sex is either 1, 2, or 3 on their priority list any time of the day, any day of the week. And with any stress goes higher up their list. Because for men, sex is a release. I believe that for women, it's rarely above a 10 or a 12 on their priority list any time of the day, any day of the week, and with any stress at all, gets pushed further down the list. And I think God's up there laughing, look how different I made them. They're supposed to live together and like it. We're just different. And again, this is another area where you can either sit back and cry about it, or you can just accept it for what it is and figure out how to meet in the middle somewhere. Because it just is what it is. I don't think there's anything wrong with either one. But interesting that for a man, he looks at his wife and he says, if you're under so much stress, let's go have sex. That'll just make you feel better, right? Because it makes me feel better when we have sex. It's different because for a woman, it's like that's one more thing. So one more person that wants a piece of me. So I think our hurried lifestyle is probably the biggest deterrent when it comes to desire. Arousal is probably, in my estimation, more related to the fact that a woman can't really turn her brain off. I used to tell the joke, if you will, that men only have enough blood to fill one head. But the honest truth is, we women are a little jealous. Because when a man's thinking about sex, he doesn't think about anything else. And women, wouldn't you love to just be able to focus like that? So we make a joke about women. I'm making my store list. I've got to take care of that wash. I got those dishes to do. I got that appointment tomorrow. But the truth is, we have a very difficult time turning our brains off. So very difficult to be aroused when your brain's not working with you. Pain is a real problematic sexual problem, because when you've had pain with intercourse, each subsequent time you do this, and every time you do this, it gets bad again. And your brain says it's gonna hurt, it's gonna hurt, it's gonna hurt. Yeah, if you tell yourself it's gonna hurt, it is gonna hurt. And if you clench, if you take that opening and you do this to it, yeah, it's gonna hurt. It is. So it's a very difficult thing to work with. It takes a lot of partner patience and understanding. It takes a lot of work on our part as providers to coach patients on what they can do to make that pain better. And certainly, well, you got to relax. But there's one thing that, this is one of my soapboxes. There's a couple of you in here, I think, that have seen me as a provider, so you know I'm going to say this. This is my leave your crotch alone speech. I believe that the greatest source of pain with intercourse is the fact that women over-cleanse. That area down there never needs to see a cleanser. No soap, no body washes, feminine washes, wipes, sprays, no washcloths, no scrub brushes, no loofahs. That's very sensitive tissue, and water in your fingers is all you need down there. And I could tell you some horror stories of the things that patients come to me having done down there, and then they wonder why it hurts to have sex. That tissue there, to me, should feel like your hands do after you've used a real good heavy hand cream. There's a film there. And the older we get, the less of that we make. So really important, especially as we age, that we don't wash all that away. So water in your fingers is all you need. And for those of you out there with a handheld shower head, you know, don't trade it for spraying, because basically what you do when you spray is you douche not only your vagina, but you douche your urethra. It's way too much pressure, if you will, water pressure down there. So if you use a shower head like that, you spray it in your hand and splash, never a direct spray. So I truly believe that's the #1 source of pain with intercourse. And I am sad when I see a patient who's come all the way to see me for pain with intercourse, and I swab it and look under the microscope, and what she's got is a garden variety bacterial infection, which you get from over-cleansing. And when you have a bacterial or a yeast infection and you have intercourse, you end up feeling like you've had intercourse with a sandpaper penis. It's not comfortable, but a very simple thing to fix with the right medications. But once you've had painful intercourse several times, it can be difficult to break that cycle. Moisture is very important. I'm a big proponent of various lubricants. As we age, we don't do as well with the water-based lubricants. When you use a water-based lubricant, it worked real well when we were younger, but as we age, you know, that water-based lubricant, it's kind of like licking your lips. You put it on, you feel real good the minute you put it on, but it doesn't take long and it gets gooey and gummy. So I'm a big believer in a silicone-based lubricant, and my favorite is olive oil and coconut oil. You got them on the shelf in the kitchen. So when you use olive oil and coconut oil, just the plain stuff. So don't use any of that olive oil that's got herbs or garlic and anything. Just plain olive oil, please, please. And then difficulty achieving orgasm. You know, another horrible fact that you know, just gonna make you moan on the inside is that as we age, it's harder to get an orgasm, it's shorter, and it's less intense. It just is what it is. So you got to work at it. And that crass phrase, use it or lose it, that applies down there. So I always tell my patients who have sexual issues, abstinence does not make this problem any better. Abstinence isn't going to make it any better. With that said, the other thing I really emphasize is, especially when it comes to pain with intercourse, another cause of that is hurrying up the process. Okay, if we just do this quick, just get it done, just hurry up and finish. When you do that, you've not given your body the time to lubricate itself. You've not relaxed. So foreplay is very important. Foreplay has a purpose physiologically. Your vagina will tent. It produces some of its own moisture. So don't skip foreplay. That's really important. Take time. Take time.
I have a question.
Yes?
Can lack of hormones cause pain?
So the question is, can lack of hormones cause pain? I don't think you can say directly a lack of hormones cause pain, but a lack of hormones can cause a cascade of events that ultimately can cause pain. For example, estrogen. Without adequate estrogen, the tissue here gets thin, pale, and dry. So thin, pale, dry tissue is not as comfortable having sex. You don't have the cushion, you don't have the lubrication, you don't have the texture. So in that respect, it does. A lot of causes for female sexual issues. Certainly I think you can understand there's medical and physiologic, there's social issues. I think the hardest one to deal with is relationship issues, and the most important aspect of sexuality is being able to communicate with your partner. Very important. I could stand here all night and tell you some really wild stories, but I think the saddest stories are the patients that come to me and want me to help them want to have sex with their husband. And I can think of two patients in particular, one who was having a 10-year affair. Sex with her lover was great, sex with her husband was not, but I'm never leaving my husband. And the other was gay. Sex with my girlfriend's great, but can you make me want to have sex with my husband? I'll tell you that in both those cases, I told those women, if you would put it, I believe if you put as much energy into your marriage as you're putting into your affair with either your male or your female lover, maybe you could make this work. So it takes a commitment on both your parts. Harriet Lerner again says, be wary of a narrow medical model. Sexual desire is far too emotionally complicated to reduce it to hormones and to the function or dysfunction of your parts. My best advice is to realize that you're okay just the way you are. To decide that you won't be a physical partner because you don't feel like it is like deciding that there'll be no more conversation in marriage because you're not a talker. So again, communication with your partner, I think, is really critical. Another one of my favorite slides is the comparative complexity. This top part is the man. It's just an on and off switch. Sometimes I'll tell my patients that I think male sexuality is kind of like that light switch, on and off, you know, and as they age, you might put a dimmer switch on it, but it's about as complicated as it gets. And for women, it's bells, whistles, knobs, you know, a little more complex. In all fairness to the men, I think part of the problem that we have is expecting that he has to know how all of these knobs need to be lined up. And I think it's our responsibility to line some of those up ourselves. I think that's really important to recognize that you can't leave it all to him. You know, you have to prepare yourself. A lot of hormonal issues, not just the sexual hormones, but thyroid problems. Some of the medications patients take can affect the hormone levels. We certainly know if there's anything going on in the pituitary and the prolactin level goes up, the libido just tanks. Poor blood flow. You know, one of the things that the urologist does for a man that's coming with erectile dysfunction is make sure first that he doesn't have diabetes and hypertension. Those are the two red flags. And men were more likely to show up with ED than they will complaining about issues related to diabetes and hypertension. So very often they get their diabetes and hypertension diagnosis because they went in because their penis wasn't working anymore. So, neurologic. Neurologic issues in my world are the most frustrating thing because they're so unpredictable. Spina bifida, multiple sclerosis, pelvic trauma, stroke, they're so unpredictable, and one of the things that they do is they affect the body's response. There's kind of a short circuit, you know, so the response is not the same. Pelvic floor dysfunction. Your pelvic floor muscle is a hammock of muscles that in women, the urethra, the vagina, the rectum pass through. In men, the urethra and the rectum. When you urinate, pass gas, have a bowel movement. For women with intercourse, for men when they ejaculate. The pelvic floor muscle ought to be able to get out of the way so you can do those things unimpeded. But you want that muscle strong enough and under your control that you can use it. So we see two things in my world. We see a pelvic floor muscle that's atrophied and you can't find it. It doesn't work for you anymore. Or we see patients who are all knotted up. When that pelvic floor muscle stays tight like that, for men it can cause erectile issues. For women it can cause such severe pelvic pain they have pain with intercourse. For men and women it can cause urologic problems, it can cause bowel issues. So it's very important to have a healthy pelvic floor, one that you can not only contract but that you can relax. Urologic and gynecologic problems. Let me just put a plug in here with pelvic floor and urologic problems for a product that's on the market. I don't have any stock in the production of this, but have you heard of a squatty potty? I should have had a picture of that here. A squatty potty was developed by, actually I think a practitioner that was trying to help people learn how to squat to urinate and have a bowel movement. And it's actually a stool, if you will, that sits right there against your potty so you can pull it out when you need to sit and urinate or have a bowel movement, and you can put your feet up so that you can actually relax your pelvic floor. I am encouraging more and more and more patients to buy one of those because what we're doing in our society right now, and some of you may have already done this, is we're installing these toilets that are taller because they're easier to get on and off of. Well, when you have a toilet that's easier to get on and off of, you're not in a natural squatting position to be able to urinate and have a bowel movement, and we end up with this pelvic floor dysfunction and more urologic and GI issues because you don't relax. So it's called a squatty potty, and I saw them at Target and at Bed Bath & Beyond. You can also go to like squattypotty.com and read up on what I'm talking about trying to get your pelvic floor more relaxed. Their ads are horrible. I don't know who they got to do their marketing, but their ads, when I've seen them on TV, are embarrassing. They're just awful. So, a lot of different medications can cause sexual issues, both male and female. So you have to look at what medication am I on, and is this causing me to have no desire or not being able to be aroused? This one says, I'm going to skip exercise class today, Allie. I've gotten enough of a workout doing high impact mothering. I put this slide in again to say part of the problem is we are so busy. And this goes for men too. We don't know how to slow down and relax and enjoy life. And sexuality is a part of that process. So I'd encourage you, if this is your issue, and I'm assuming that if you're here tonight, it's not just to hear me talk or to support the Cancer Council, it's because you're interested in this topic. You got to put some effort into it. A lot of psychological causes, particularly in patients who have had cancers and changes to their body. You know, when your body doesn't look the same. Well, most women, we deal with that anyway because gravity is really not our friend. So when we look in the mirror, we don't see the same thing that we saw several years ago. Surgery can cause that, radiation can cause it, chemo sometimes can cause some really drastic changes in the body. Chronic illnesses can. Depression and anxiety, talk about a big libido buster. You just don't feel like doing anything. Don't feel like participating in anything, much less sex. Anxiety is a real killer because it's very difficult to relax when you're super anxious. Prior sexual or physical abuse, this is a real sad one because I see women that are in their 50s and 60s, and I ask, any history in your past anywhere of anything like rape, molestation, inappropriate touch, incest? And I've had patients in their 50s or 60s tear up and say, I've never told anybody this before. So let me help you understand what happens. A lot of it is trauma that happens to children. And remember that the cognitive level that you were at when that trauma or abuse occurred is where it's stored in your brain. So when you recall it, for example, at the age of 8. So if you think about where you are cognitively at 8, there's a lot of shame involved, there's a lot of guilt involved. As a 50 or 60-year-old woman, you know that was inappropriate, it shouldn't happen, but your inner child is remembering it at that age. So it takes a real professional to help you take that memory out, lay it out on the table, look at it, and put it back in your memory banks with a better memory. In other words, you're never going to forget things like that happened to you. And anybody that tells you should just forget it is absolutely insane because you never forget trauma like that. But you need sometimes a professional to help you remember it in a way that's healthy for you, that doesn't disable you anymore. So put it back in your memory as an adult. I didn't deserve that. I didn't ask for it. There's no reason for me to feel guilty. It takes a professional to do that, especially if you've carried it for 50 years. So I see that a lot. I do believe I've seen patients that I know there is some physical abuse going on. Though I welcome men coming in with their wives when I see them. When a man leaves the room so I can do an exam, I always look at the woman and say, is there anything you want to tell me now that it's just you and me? Because sometimes there is some controlling and some abuse that's going on, and it's very difficult for a woman to want to have sex with somebody that's just beat the pulp out of her. I always ask my patients, do you love your husband? Do you like him? Women, we really want to like who we're having sex with. No offense, you guys, but you don't have to like who you're having sex with. Women tend to need to like who they're having sex with. Alcohol and substance abuse, I see this both directions. I see it in the patient who's abusing substances or alcohol, and when they do that, then it really is a libido buster. Hard to get aroused when you're tranquilized or you're on a sedative of some sort. Relationship issues, I wish I could put a big star there. That's one of the biggest things that I deal with, and that's not my specialty. So what I tell patients is, look, I've got a very healthy respect for what goes on in here. Your heart and your head, that's what I call them, heart and head issues. It's not my specialty, but I respect that both personally and professionally. And I don't recommend to all my patients that they need to see a therapist, but most of them I do, because that's not my job to tease out, is there something in here that you need to deal with? My job is physically, is your body able to give you the response that you want? Sociocultural, there are cultural differences. There's conflict with religion on a regular basis. I've said that if I can make a difference in this world, I really would like to make a difference in the church. I consider myself to be a deeply spiritual Christian, and I think spiritual Christian women are some of my most difficult patients. They've got hang-ups. And I think that's really sad, because I do believe in what the Bible says, that we are fearfully and wonderfully made. I think it's very interesting that the clitoris is the only part of either a male or female body, the only part of our body that only serves one purpose. It's pleasure. That's it. I just can't believe God would have created us with that if He didn't intend for us to put it to use. So I think that's an important perspective. Inadequate education, I can't tell you enough how important it is for us to understand our own bodies. I truly believe that we do our young people a disservice by making it taboo to talk about sexual things, to talk about our bodies. I think it's very important from a very early age to talk about the body parts just as their name, not cutesy little names for them. Kind of a matter of fact, this is how your body functions. Interpersonal causes, I love this. Okay, we took our clothes off, I got on top of you. How long till it starts feeling good? I don't know, but I got a headache already. Partner performance is really, really important. And this would really go both ways, but from my perspective as a woman, because I see female sexual health patients, when a man has erectile issues, it is not very comfortable to have intercourse with a penis that doesn't get hard enough. In fact, it's very uncomfortable. And the process takes so long. The friction that's involved with that and the amount of lubrication that's required make it eventually, this just isn't working for me. On the same token, for women, if a man is turned on by his wife and is coming to her with a very erect penis and really wants to pleasure her, and she's planning her store list or thinking about what appointment she's got tomorrow, men have an innate sense of knowing whether you're there with them or not, and that is a major libido buster, a major arousal buster. Any conflict in the relationship can be a problem. Lack of privacy. And this comes from, I'm seeing a lot of women my age and older who have boomerang kids. They had this empty nest, everything was fine. Now their kids have come back. So they got this house full of kids, whether it's their own or their grandchildren, and there's no privacy. And then partners' responses to body changes. And this goes both ways. When we are looking at the body and how it's changed, not only with aging, but with the things that have been caused by chronic illnesses, and cancer is one of them. So when you look at the medical community, in the last couple decades, we finally started paying attention to female sexuality, that it's just as important as male sexuality. I think Viagra, the way Viagra was presented not only to the medical community, but presented to the general public, was a real disservice, because there wasn't enough education involved. So they just bring it to the market, And men are going and getting all these prescriptions and urologists, and they'll tell you they were just writing it hand over fist without a discussion between the husband and wife about whether this is something they wanted to do. So I was in gynecology at the time, seeing women whose tissues were just torn and obliterated by intercourse that they hadn't had for years, and he came home with a bottle of Viagra. So luckily we learned a little bit about that, and now we're realizing, this is something, sexuality is a couple's thing. It's not just, when I treat the female for sexual health, it's very important to bring the partner into the mix. What does he want in this? On the same token, when a man goes into a urologist, if he's a really responsible urologist, he's going to ask, where does your wife play a part in this? Does she know you're here? Does she know you're asking for a penile prosthesis? Does she know that you're asking for this Viagra? Behavioral therapy, I think, is really important. I'm a big proponent of what I call erotic bibliotherapy, where you read books and see if they arouse you. Personally, I don't like erotic reading material that's got a lot of foul language in it. Doesn't do anything for me. That's just my upbringing. So I read 50 Shades of Grey. I read all 3 of them because I knew my patients were going to come in. And there's a lot of aspects of that kind of sexuality that don't appeal to me. It doesn't turn me on to know somebody's gotten tied up and slapped. But I'm not here to judge if it turns somebody else on, and a couple, that's what they do. I do believe that you have to be willing to experiment different positions. Things change as our hips don't work the same way, our knees don't work the same way, different surgeries that cause changes. Be willing to think outside the box and try different positions. And there's some wonderful books out there to give you illustrations on different things to try. I'm a big believer that the counselors ask us the questions we don't know to ask ourselves. So I have a couple counselors that I refer patients to on a regular basis that I like very much. I like their approach. I also caution my patients that not all counselors are qualified to talk about sexual issues. Just like in my case, not all counselors are qualified to talk about religion and my faith. And for me, if you can't talk about my religion and my faith as it applies to who I am, then you're missing a big part of me. So you have to find the counselor that has the training, the knowledge, and actually the passion to want to deal with this issue, because some people are just not comfortable talking about it. Some healthcare providers are not comfortable talking about sexuality at all. But it is all about interpretation. This is a drawing that a kindergartner did when he drew a picture of scissors. So you'll have to make sure that when you put this program on the video that you get this one so they can see what it is. Topical therapy, I think vaginal lubricants, use them liberally. Don't be ashamed to use them. Pornography has really not been good for us, because as far as pornography is concerned, a woman is ready for you when she's wet, and you've aroused her if she's wet. Well, as we age, we don't get as wet, and it has nothing to do with our desire level or how aroused we are. So don't be embarrassed or ashamed to use a lubricant. I'm a big proponent of vaginal estrogen. I keep saying you're going to have to pry it out of my cold dead hands, because I believe in what it does for the health of that tissue down there. It's available in cream forms, a ring, or tablets that you can put in.
That's the question I have about that. What if you've had cancer?
So the question is whether or not you should be able to use vaginal estrogen if you've had cancer. And in answer to that question, hormones are probably the most controversial thing in medicine. So if you went over to the Health Science Center, you can find just as many articles that say it's no big deal as you're going to find saying, oh, no, stay away from that for the rest of your life. Some of the latest research coming out is saying, in fact, the North American Menopause Society is pushing the FDA to take the black box warning off for these vaginal estrogens, because there's such low doses. Now, with that said, that's between you and your oncologist, because your oncologist knows exactly what your cancer was like. I can tell you, though, I'm seeing a lot of patients whose oncologist, when they express to their oncologist the discomfort that they're having, are allowing them to do this, and we're watching their levels to see that we're not stimulating anything. There are also a couple of cancer drugs that literally suppress all of your estrogen in your body, so using an estrogen won't work because you're taking a medicine that's going to keep it from being absorbed anyway. So we like to involve the oncologist in each patient and treat them individually. So there's not a blanket answer to that, but it's not as scary as we first thought. But the FDA says estrogen is estrogen is estrogen. So whether you get the highest dose birth control pill on the market or the lowest dose vaginal estrogen, the warnings all read exactly the same: heart attack, stroke, blood clots, cancer.
And does it help to restore the thin, pale, dry?
The question is, does it help restore the thin, pale, dry tissue? And I do tell my patients, I think there is a point of no return. You're only going to get so much better, especially if it's been a while since you've used anything. But yes, I've seen patients they're made almost 100% better just by adding back just a little bit of estrogen. And the nice part is you really don't need much. Some of you are too young for this, but how many of you remember the Brill Cream commercial? A little dab will do you? A little dab will do. You don't need a whole lot. That's what's nice about using vaginal estrogen, and it really makes a difference. I especially see that in the urologic world, because the urethra is very much, I call that your faucet, very much affected by no estrogen. And as women, our urethras are about as long as your pinky fingers. So picture that urethra that's the skin's getting thin, pale, and dry, and it's just separating, and your faucet's having a hard time staying shut. So I think vaginal estrogen, I think it's important. Testosterone is another one of those hormone levels that is really controversial. ISHWISH is the International Society for the Study of Women's Sexual Health. Every year they talk about testosterone, and there's just as many people in the it really works well and you need to use it as there are in the camp that says, it doesn't make that much difference. So I'm not opposed to using it for a woman if she would like to try it. My personal professional experience has not been good with it, but I'm willing to try. When I try, though, I am going to do levels. I'm going to see what your baseline level is before we start, and we're going to go very slow. There are no FDA-approved testosterone supplements for women. There's one called Estrotest. It's an oral estrogen testosterone replacement. But in the literature, you've seen over and over and over that oral replacement for testosterone is really inadequate. So the topicals is the way to go, but we're having to use male equivalents. Testim, Androgel, Axiron is the one that goes under the arm, so it's a liquid, so I use that sometimes.
So the estrogen receptors, does that affect or like what vaginal estrogen replacement would be recommended?
So I think your question is, do the estrogen receptors that they test you for related to your cancer have anything to do with what vaginal estrogens you can use? No, because those are the ones I showed you all there are estradiol or Premarin, which is a conjugated equine estrogen, and there's really no choice. I mean, it's either the vaginal estrogens or not. So really what it amounts to is whatever your oncologist says about your particular cancer, whether you're able to use any estrogen at all. I've seen quite a few patients that the oncologist is more comfortable when you're 5 years out, or if you're not on, and I'm not in oncology, so I'm not going to pretend to pronounce any of the medication names, but there's a couple of them that it's really contraindicated to even try to use it because it's not going to get absorbed. So that's why we got to involve your oncologist. A lot of helpful organizations, and this is off of the Interstitial Cystitis Association's website. Interstitial cystitis is a condition of the bladder that tends to cause a lot of sexual issues. So it's just all of the different organizations that you can go to, find them on the web, and get helpful information. So I'd like to close with the 10 Commandments of breast cancer, and you have that on your handout there because I think it's really, really important for us to focus a little bit on what's important. Give yourself time to think. You know, you don't need to make split-second decisions. Honor your own feelings, and you have a right to feel and work through your own feelings. Don't judge anybody else's decisions on how they decided to treat their cancer. Love yourself as you do your neighbor. I think that's really important when you're dealing with any chronic illness, but particularly with cancer, is to get to know yourself and love yourself. Don't beat yourself up. Allow others to help you. This is a really big one because sometimes it's difficult to let people do things for you. Don't bear false witness against science. You know, I like to say we're doing the best job we can with the information we have right now. But I believe that though we know a whole lot about the human body, we got about twice as much left to learn. So we're doing the best job we can. You know, this one applies to me right now because my dad died 5 years ago of metastatic melanoma. He died 5 years too early because now we have 5 drugs. You know, he would be here. So we did the best we could at the time. Ask questions. Ask questions. This came out of Reader's Digest magazine, one of my favorite journals. The only thing I would like to do there is change that to ask your healthcare provider because your nurses have your answers also. Seize the day and remember that you're more than your cancer. So in my slides, whoever asked, are my references at the end. So other questions? You're a real quiet bunch tonight. Real quiet.
Thank you so much. That's great. We appreciate it. Does nobody have any questions for Peggy?
I'm happy to have you come look at my books. These are 2 that the American Cancer Society will give you that you can get through the American Cancer Society. So ask them.